This patient came to see me in 2021. Take a look here. For endodontic treatment of tooth number 30. He had traumatized the tooth earlier, and apparently he was hit in the face with a metal bar and traumatized tooth number 30. Tooth had all the signs and symptoms of irreversible pulpitis with acute apical periodontitis. It looked like perhaps maybe some resorption going on as well. So we had gone over options with the patient, recommended root canal, also spoke with the patient regarding extraction. Patient wanted to try to save the tooth, right? Well, he left and he never scheduled for a root canal with us. And again, as you can see, when we saw him was 3 years ago, 2021. Well, a few days ago, patient came back looking like this, saying that tooth was hurting him a lot. He was in a lot of pain, and he had gone to another endodontist and gotten the root canal done there. I have no issues with that. I have no problems with that. And apparently the endodontist had gone through his crown and done the root canal, but he was in a lot of pain, and he was like, I don't know what's going on. Well, take a look here. So again, the endodontist had gone through the crown, and as you can see, that's the date when I first saw him. Today is 7/2/2024. So when I saw him was 3 and 5 days ago, and this was the condition of the tooth. He had gone to another endodontist for the root canal. The endodontist had gone through his crown and done the root canal for him. And he said the tooth was fine, and now it started to hurt again, and he was in a lot of pain. We couldn't even touch the tooth. Percussion tender, palpation tender, probings were 2 to 3 millimeters, 2 to 4 millimeters all around. And take a look here. So you can see the 2 mesial canals. You can see the distal canal here. And take a look here. What's going on here? Again, probings were 2 to 3, 4 millimeters. So probings were within normal limits. But what's going on here? Well, usually when I see something like this, I suspect 2 things: either a fracture, a crack root, which in this case did not believe was the case, or miscanals, or misroot, or miscanals. And take a look at the different angulation x-ray. So that's why it's important to look at different angulation PAs. You're welcome to get a CBCT. I'm just very comfortable with looking at a couple of different angulations PA, and I can usually about 99.5% of the time make my diagnosis based on multiple angulation PAs. I personally don't need a CBCT, but if you want to get a CBCT and can read it properly, can read it. Don't send it to me to read it for you. You order it and send it to me because you can't read it, for me to read it. And that happens on a daily basis, that one of you send me a CBCT and you say, I can't read it. Can you read this for me? Then if you can't read it, why did you order it? All right, so look at this angulation here, and immediately you can see that this gutta-percha is not centered. Take a look here. The distance from the outer surface of the root to the gutta-percha is shorter here compared to this side here, right? So that tells me that there's very likely a missed canal here. That dentist missed a canal there. All right, so I went over my findings. I went over options with the patient, and the patient wanted to try to see if tooth could be saved, and that's what we did today. So we went through the previous endo access that was restored with composite, and as I was going through it, the crown came out. And I noted that the mesial wall here, there wasn't really much wall left, and that's probably why this crown was not fitting well to begin with. So I rebuilt that mesial wall with the composite temporarily, because I need 4 good solid walls, and walls need to be long enough to hold my irrigants. All right, so take a look here. Let me show you the post-op. Remove the gutta-percha. I use chloroform to remove the gutta-percha. And take a look here. Here's the post-op. We redid the root canal for him in one appointment. Let me show you a different angulation, okay? Look at a different, let me show you a different angulation here. Look at this angulation here. So this endodontist had missed 2 distal canals. So now you can see 1, 2, 3, 2 distal canals and a bunch of anatomy on the mesial. You can see all the anastomosis between the mesial roots. Let me show you a different angulation here. Here we go. Again, you can see. So now you can see that everything is nice and centered. But yeah, when you miss canals, when you leave necrotic tissue behind, when you don't address the anatomical complexities of the root canal system, it doesn't matter if you're an endodontist, like this gentleman who had treated this tooth prior to me, in this endodontist, or a general dentist. If you don't address the canals, find them, locate them, and then address them properly, and address and find, locate, and appreciate and address the complexities of the root canal system, of course your root canals will very likely fail. All right, so you can see here that we were able to locate the missed canals and 3-dimensionally instrument, irrigate, activate, and obturate 3-dimensionally. So I'm very optimistic. You can see all of this anastomosis between the mesial canals here. And you can see 1, 2, 3. So this endodontist had missed 2 distal canals, and of course all of these complexities that we were able to address. So we went ahead and temporized the tooth and referred the patient back to his dentist. Take pride in what you do. Take pride in what you do, okay? So here we go.